Welcome to the workshop, Multiple Myeloma, Maintenance Therapy to Prolong Survival and Improve Life After Transplant. My name is Marla, and I will be your moderator for this workshop. It is my pleasure to introduce today's speaker, Dr. Lizamarie Bachier. Dr. Bachier is a board-certified hematologist-oncologist and attending physician with the Blood and Marrow Transplant Group of Georgia at Northside Hospital Cancer Institute in Atlanta. Her clinical interests include improving outcomes after allogeneic hematopoietic stem cell transplant and expanding access to novel cellular therapies for older and frail populations. Please join me in welcoming Dr. Bachier.
Thank you, everybody. It's a pleasure to be here. I'm speaking in the symposium. Thank you, Marla, for the introduction. We will start our talk. Again, the talk is Multiple Myeloma, Maintenance Therapy to Prolong Survival and Improve Life After Transplant. These are some learning objectives that I hope to discuss today. We will first learn what multiple myeloma is, how it's diagnosed and staged, identify the treatment schema for newly diagnosed multiple myeloma patients. We'll talk about what is maintenance treatment in multiple myeloma. We'll learn about different treatment strategies used for maintenance and why are they used and how we should use them. But before we go into this talk, let's review a little bit about what is multiple myeloma. Like I tell my patients, I am a blood cancer doctor, which means I treat blood problems. Multiple myeloma is a type of blood cancer from a specific type of blood cell called a plasma cell. When we look at our CBC, we have different types of cells in the body. There are white cells to help fight infection, hemoglobin to carry oxygen, platelets to help with clotting. These white cells that help fight infection are of many different types. One of them is called a plasma cell. Plasma cells normally make antibodies to help fight infection. For example, we get sick, plasma cells become activated, they make antibodies, we feel better. Multiple myeloma happens because these plasma cells have mutated, they have changed their DNA, they are dividing out of control, and they're making abnormal proteins called M proteins or M spikes. Multiple myeloma is more common in African American patients as well as male patients, and the median age of diagnosis is 69 years. This is a little schematic about the plasma cells in the body. So we can see here plasma cells down here. They usually live inside the bone marrow, and their normal function, again, is to make antibodies, help fight off infection. When these cells decide to start growing out of control, they make these abnormal proteins, these abnormal antibodies that have no reason to exist other than to cause problems. And it is because of this overgrowth of plasma cells crowding the bone marrow space and the production of these abnormal antibodies that we have all of the symptoms of multiple myeloma. And there was a mnemonic that we learned in medical school about the symptoms of multiple myeloma called the CRAB criteria. You might have heard this before. The C stands for hypercalcemia or elevated calcium. These plasma cells, when they chew up bone, it releases calcium into the body, and elevated calcium can cause a whole sort of different symptoms. The abnormal proteins can clog up the kidneys, essentially causing renal failure or abnormal creatinine. Because of crowding of the bone marrow space, other normal cells are unable to grow, and anemia can happen as a result of that bone marrow crowding, as well as bone pain. Multiple myeloma cells, or these plasma cells, have a predilection for migrating into bone and causing bone fractures and bone pain. Multiple myeloma is diagnosed with blood work. These abnormal proteins cause an elevated total protein. Again, if we have somebody who also has an elevated calcium or anemia, we can suspect multiple myeloma and order the specific blood test to look and see if, in fact, these abnormal proteins are present in the body. Another test that is crucial in diagnosing multiple myeloma is body imaging, either a CT scan or a PET-CT, to look and see in the body where there is evidence of these proliferating myeloma cells. And of course, a bone marrow biopsy, they are not pleasant, they are uncomfortable, but bone marrow biopsies are the diagnostic test to look and see directly at the factory of the blood and see what these plasma cells are doing, what percentage of plasma cells are present in the bone marrow. And it is with bone marrow biopsies that we can send a lot of specific genetic tests to risk stratify multiple myeloma. And there's 3 different stages of myeloma depending on how much disease is present and certain mutations. This is a picture of how plasma cells look in the bone marrow space and a PET-CT of an individual who, as we can see, has these all black spots in their bones primarily. These represent proliferating myeloma cells, and they light up on PET-CT imaging. We can use a bone marrow biopsy to sort of look at the progression and the response to treatment based on the percentage of plasma cells, and it is one of the criteria that is used when we talk about response to treatment, and we'll get to that in a minute. When we look about how multiple myeloma is staged, it is very important to note a distinction between how blood cancers are staged and how solid tumors are staged. When we have a solid tumor, for example, a breast cancer, these tumors have a stage 1, 2, 3, 4, depending on how big the tumor might be and whether it is invading adjacent structures or nearby organs or tissues. A lot of patients, when they come to me, they ask me, "Doctor, am I stage 1, 2, 3, 4?" And I have to explain that in blood cancers, staging is different, and in myeloma specifically, there's only 3 stages based on how much disease is present in the body. And a way to kind of understand this is that different than a solid tumor that might be confined to an organ, the blood migrates throughout the whole body, right? So our blood is essentially circulating throughout our tissues. So there really cannot be a stage 1, 2, 3, 4. The stages that we use are based on how much disease is present. And this is called the Revised International Staging System. And there is 1, 2, 3 stages. And how we stage it is based upon how much of an abnormal protein called beta-2 microglobulin is produced in the body and how that affects your albumin. So albumin is a normal protein that our body produces. It is a measure of how well nourished we are. Our liver produces albumin. When multiple myeloma happens, there is such an overproduction of other cells of the M protein that albumin production goes down. So depending on your albumin levels, which usually go down in multiple myeloma, and your beta-2 microglobulin levels, which go up in multiple myeloma, you'll have a stage 1, 2, or 3. And again, this is based on numerical values of those 2 tests, the albumin and the beta-2 microglobulin. Other predictors of stage 1, 2, and 3 include an LDH, or lactate dehydrogenase. LDH is a measure of cell turnover. When there are a lot of cells in the body, there's a lot of production of LDH. Therefore, if there's a lot of multiple myeloma cells, LDH goes up, and that essentially means that there's more tumor burden. Another thing that us hematologist oncologists look like for risk stratification and also to predict for response to therapy is something called cytogenetics, or DNA test or molecular test. Now, our body has DNA that makes up essentially the building blocks of all the cells in our body. Multiple myeloma cells also have DNA in the cell nucleus. And then myeloma happens again because this DNA inside these plasma cells has mutated. So a very important test that we often send from the bone marrow is chromosome testing, or something called FISH testing. And I'll talk about this more in the Q&A because I see some questions about predictors of response to therapy, and cytogenetics and FISH studies have a lot to do with that. There are some mutations, for example, some changes in the DNA that predict for more aggressive disease versus less aggressive disease. So we also use these chromosome changes when we talk about staging multiple myeloma. Now that we've had a little bit of background on how we diagnose and stage multiple myeloma, let's move on straight to treatment and specifically maintenance. But before we talk about maintenance, we need to learn what are the goals of treatment in multiple myeloma. When I have somebody that's newly diagnosed with multiple myeloma, I explain to them, in 2025, multiple myeloma, while not considered curable, is highly treatable. So the goals of treatment are to induce remission. Remission is when we don't see myeloma cells anymore, and try to maintain, the word maintain, maintenance, maintain that remission for as long as possible. So again, not curable, highly treatable. Remission means we don't see myeloma cells. It does not equate to cure, but not seeing myeloma cells is pretty darn good. And our goal, again, is to have people stay in remission for 10, 15 years instead of needing treatment every year. Myeloma exists in like a roller coaster where patients will be newly diagnosed, they'll get treated, the myeloma will go away, and we know that eventually the myeloma can come back months or years later, and then the patient will need to be treated again, go in remission again, myeloma relapses, treatment again, and it's like this roller coaster of myeloma relapsing and remitting. The best chance at having a prolonged remission duration is with the first treatments that we do, because we know that at that point, these myeloma cells have not yet seen any therapies. Therefore, they cannot get smart enough to escape chemotherapy or become resistant to chemotherapy. So there's a three-step process for newly diagnosed multiple myeloma that involves induction, consolidation, and maintenance. Induction, I call it the tumor debulking. That's the initial chemotherapy that an oncologist will prescribe to get rid of as much myeloma as possible. In this day and age, standard of care is usually 3 to 4 drug regimen, including an immunomodulatory drug, which is usually Revlimid or lenalidomide, a proteasome inhibitor, which is usually Velcade, steroids at higher doses, and a CD38 antibody called daratumumab or Darzalex. So that's the initial induction. And the oncologist will give this induction therapy for about 4 to 6 cycles to, again, get rid of as much disease as possible. About 70% of the time, patients will induce a VGPR or better after induction. But then what happens next? We do the consolidation in patients who are fit for transplant, either a transplant or more cycles of chemotherapy. The goal of consolidation is to deepen the response that you've achieved with your induction. So if you've had 4 cycles of induction chemotherapy and you've achieved a VGPR, which we'll talk about in the next slide, then the oncologist might send you to a transplant center for consolidation in order to deepen that response. Now, after consolidation, hopefully the majority of patients are in complete remission. Then comes the maintenance, which is usually 2 years at minimum, and it's 1 to 2 drugs used to prevent myeloma from returning. Briefly, when we talk about response criteria in multiple myeloma, you might be familiar with the terms PR, VGPR, CR, stringent CR. These terms are what we use to classify the response to treatment, ranging from a partial response, that's a PR, a very good partial remission or partial response, a complete remission, or a stringent complete remission. And the way that we decide if someone qualifies for these response criteria is based on how much disease is left over. And this is relative to when they were first diagnosed. So for example, if a person at diagnosis had 50% plasma cells in their bone marrow and an M spike of 4 grams per deciliter, for example, and they have a 50% reduction, they're in a partial remission. If they have a 90% or greater reduction in tumor burden, they're in a very good partial remission. Complete remission means you don't see any abnormal proteins in the blood and you have less than 5% plasma cells in the bone marrow. And when we talk about stringent CR, not only do you not see myeloma proteins, you have normal free light chains, and you don't have any clonal plasma cells by immunohistochemistry in your bone marrow biopsy. So again, going back to the beginning, these bone marrow biopsies are important because we use them to determine response criteria. And response criteria are important because it allows the oncologist, hematologist, to guide decisions regarding treatment, including consolidation and maintenance. And so, for example, if after induction you've achieved a VGPR, perhaps consolidation will move that patient into a CR, and the maintenance treatment that we use might help keep that patient in a complete remission for a longer period of time. Now let's move directly into maintenance. What is maintenance? Why do we use it? So maintenance therapy is chemotherapy that's given, it's usually after an autologous transplant in patients that are eligible for transplant, and it's given for several years in patients with multiple myeloma. And why is it given? What's the goal? It's to prevent disease progression and death. What drugs are used? So the preferred drug right now is lenalidomide or Revlimid, but there are other drugs that have been studied and used, and we'll go over that in a second, including Velcade, which is bortezomib, Marrow, which is ixazomib, Darzalex, which is daratumumab, and Kyprolis. And before we go into what does the data show, I'll answer a question that patients often ask me. Doctor, if I'm already in remission after my induction and my consolidation, then why do I need maintenance therapy? What is the purpose of all of this if you're telling me that I'm already in a complete remission? And the purpose of maintenance, why we use it, is because it's been shown to prolong survival, because we know that even if by conventional testing a person might be in a complete remission, our methods of detecting myeloma are not perfect, and there might be myeloma cells hanging out in the body that we cannot detect through our conventional testing, even though we've gotten very good from a scientific standpoint. We've gotten very good at detecting disease at very microscopic levels. It is not perfect, and we know that there can be cells hiding in the body, essentially biding their time to come back, even in patients that are in remission. And by using maintenance strategies, we can have sort of like, think about soldiers that are surveying the blood, and if there's any myeloma cells trying to make a comeback, the idea is that a person on maintenance will stay in remission longer because they don't have a lot of tumor burden, and these drugs, which is usually, again, only one or two drugs, are very safe to give with a side effect profile that can be managed, and with the benefit of allowing people to live longer and their myeloma staying away for longer. So we're going to talk about a couple of different drugs that are used for maintenance, why they were chosen, how they were chosen, and how we get them. And the first one, because it's the most common one, is lenalidomide or Revlimid. Now, mind you, a lot of this data, it's 2025 right now, and a lot of these trials were done in 2005. So it might seem like not that long ago, but this is already 25 years old. Data that is 25 years old, 2000s, early 2000s, 2005. So these are strategies that we've been using for the last 15 plus years, with some recent evolution in which drugs we use and how we use them. But Revlimid was the first one. And Revlimid is in the category of an immunomodulatory drug. The precursor of Revlimid was this drug called thalidomide. Thalidomide came with a lot of issues, and you might have heard, the stories of the thalidomide babies. But essentially, back in the 1990s, thalidomide was a drug that was used very frequently in multiple myeloma. And then when Revlimid came along, we essentially transitioned over to the use of Revlimid. And one of the pivotal trials, again, this was a trial that started accruing patients in 2005, was this CALGB 100-104 or IFM 2005-02. And it was a randomized trial in patients that were newly diagnosed who had received an autologous stem cell transplant, and they were randomized to either receive lenalidomide maintenance or placebo. Now, you might ask yourself, what were we doing before then? Well, before then, we were doing all sorts of different things, including giving patients melphalan, prednisone, thalidomide for induction, other types of chemotherapy, Velcade, anthracycline, and dexamethasone. So we were using kind of cytotoxic chemotherapy for induction, not so much immunomodulatory drugs. So in the advent of these immunomodulatory drugs, the question was, how can you help patients live longer? And one of the strategies was maintenance. And so these patients received induction, a transplant, and then were randomized to either get maintenance Revlimid or no maintenance. And what did this study show, and why is it so important? It's important because if you look at these survival curves, patients who got lenalidomide, which is on the top, lived longer, did better than those that did not get lenalidomide maintenance. So again, this is a randomized phase 3 trial, multiple patients on trial who were treated exactly the same except for maintenance or no maintenance. And those that received maintenance lived longer. So because of this trial, Revlimid became the standard of care in patients with newly diagnosed multiple myeloma. After induction and consolidation, the thought process was you start them on Revlimid maintenance. Now, since this trial, there had been multiple studies looking at cost effectiveness, side effect profile, and duration of Revlimid maintenance. And the consensus has been that the maximum benefit is usually achieved after 3 to 4 years. And after that, the benefit kind of tapers away. So for the most part, I tell patients, and this is sort of very broad terms, that we try to keep them on Revlimid for at least 2 years, preferably 3 or 4, likely not more than 5, depending on how they're doing. And again, we'll talk about a little bit of side effects at the end, but usually very safe, very well managed, and good tolerance profile. Since that trial came out, different groups tried to see, okay, well, what about different drugs for maintenance? And one other drug that was considered is bortezomib or Velcade. And there were a couple of trials using Velcade, both in transplant-ineligible patients as well as transplant-eligible patients. And they showed that using Velcade did improve progression-free survival without necessarily affecting quality of life. They did not show a survival benefit, but they were also comparing it to thalidomide maintenance, not Revlimid maintenance. And so what we gathered from those trials is that, yes, patients who got Velcade did better than those that did not get Velcade, but they were also not comparing it to what had now become standard of care, which was Revlimid. Nonetheless, because of this trial and the difference in survival curves between the Velcade maintenance versus not, Velcade became a second alternative, so to speak, for maintenance strategies after initial induction. One of the problems with Velcade is neuropathy, peripheral neuropathy. Imagine being on Velcade for 2 years plus at a schedule of every other week. Not only is it cumbersome to have to get an injection every other week, but the side effect profile was quite significant, with a lot of peripheral neuropathy causing significant morbidity in patients with multiple myeloma. Different from Revlimid, for example, which is a pill, and like I tell my patients, you can take Revlimid in your hometown, in any place in the country. You can take it in Europe. So if you're on a pill and you can have your pill with you, you have a little bit of freedom in terms of where you can go and what you can do, assuming you've been on a stable dose. That is not the case with Velcade. If you're on Velcade, you essentially have to be within a week or two of your doctor because it's given every other week. In addition to the two drugs that I mentioned, the Revlimid and the Velcade, which are by far the most commonly used, more recently there have been trials looking at newer drugs and combination drugs, especially in patients who have high-risk disease. And this is a case of carfilzomib or Kyprolis. And Kyprolis is relatively new compared to Revlimid, so it's 2014 or so. And this trial, the Forte trial, compared carfilzomib and Revlimid in patients who were transplant eligible, newly diagnosed, and had high-risk disease. They had induction with carfilzomib, Revlimid, and dexamethasone, or KRD. Another group had induction with carfilzomib, Cytoxan, dexamethasone. They had an autologous transplant, and then their consolidation was either Kyprolis plus Revlimid or Revlimid alone. And as you can see, there was an improvement in progression-free survival, but this came with a cost. So the carfilzomib group had a higher adverse events or side effects than those that were on Revlimid alone. So yes, you had more disease-free interval, but more side effects. And so the thought process from this trial is that while Kyprolis is a good maintenance strategy, it should be reserved for patients who have high-risk cytogenetics and high risk of relapse. Ixazomib, or Marrow, is an oral pill that is a proteasome inhibitor. So we can think of it as Velcade's cousin. So Velcade is the injection, and Marrow is the pill. And Marrow has been approved in patients with multiple myeloma, and in this Tourmaline trial, it was tested as a maintenance strategy in patients after autologous stem cell transplant. And it improved progression-free survival, but there was no change in overall survival. And I'll make a pause because I'm talking a lot about progression-free survival and overall survival just to describe a little bit about what that is. When we talk about progression-free survival, is time without needing other treatment. So for example, from the time that you start your maintenance to the time that you need to start treatment for relapse disease. As we know, patients with multiple myeloma have many treatment options these days. So even if you relapse, chances are, hopefully, you don't die because you get second and third and fourth and fifth line of therapy. I had a lady not that long ago who was on her 11th line of therapy. Overall survival is essentially how long you live. So it's time from initiation of maintenance to death. And so far, the only trial that's had an improvement in survival has been the lenalidomide group until the Griffin trial came along. So Griffin trial, this was what changed really the induction treatment in patients with multiple myeloma from Revlimid, Velcade, dexamethasone alone to daratumumab, Revlimid, Velcade, and dexamethasone. And this is on patients with newly diagnosed multiple myeloma who received transplant and consolidation, and they received daratumumab plus lenalidomide versus lenalidomide alone, and they did have an improvement in progression-free survival, and I believe there was an overall survival benefit as well. Right now, there is an ongoing trial called the DRAMATIC trial, and the DRAMATIC trial is essentially looking at induction, consolidation, and maintenance again with daratumumab and Revlimid versus Revlimid alone, and we're still waiting to see how that trial reads out, but it does seem that the addition of Darzalex to Revlimid does not have a significant impact in adverse events or side effects, and it does have an impact in survival, both progression-free survival and overall survival. I have not particularly seen a change yet in treatment in physicians moving towards dual drug combination for all patients, but it is useful for a subset of patients, especially those that are higher risk. So with this, I'm going to summarize a little bit about maintenance in multiple myeloma and move on to a couple of slides about cost, effectiveness, and side effect profile. So as of now, as of 2025, lenalidomide is the only FDA-approved drug for maintenance. But as we have seen, there are others that have been studied and that have been used. The use of drug combinations, for example, carfilzomib and Revlimid or daratumumab and Revlimid, could be beneficial in patients with certain chromosomes that predict for high risk of relapse. While there is no consensus on when to stop maintenance, many studies suggest that there's no benefit after 3 to 4 years. And it would be useful to have tools, right, to predict when it is safe to stop maintenance. And many academic institutions are working with platforms such as next generation sequencing, which are much more specific and sensitive tools to try to look and see really is there any residual disease left and when would it be safe to stop maintenance. One thing that I'll briefly discuss here is that the reason myeloma cells keep coming back is because of something called clonal evolution. Essentially, the myeloma cells become smarter over time. And so usually the first period of remission tends to be the longest. After that, with each subsequent relapse, the remission duration is shorter because the cells essentially continue to evolve, continue to become resistant to treatment, and it is much harder to keep the disease away after 3 or 4 relapses. So again, a lot of thought has gone into looking at these next generation sequencing platforms to see if someone is what we call MRD negative or minimal residual disease negative, is it safe to stop maintenance in those patients, understanding that, again, with the most sophisticated tools, we're not able to detect disease, and hopefully they stay in remission for longer. Maintenance therapy can be costly, but the reality is that you are trading one cost for another. You're trading the cost of maintenance for the cost of treating myeloma when it relapses. And I'll show a slide on this. So again, despite the higher upfront cost, the goal of maintenance is to prevent financial burden down the line by preventing relapse and actually needing treatment for the disease. In terms of side effect profile, like I mentioned, everything in life has a side effect, even Tylenol. Usually, the side effects are very manageable and can be mitigated with dose modifications. Revlimid, for example, there's a higher risk of secondary skin cancers, low blood counts, nausea, vomiting, diarrhea. These are all things that your hematologist should be discussing with you at every follow-up appointment, so that in combination with your physician, you can talk about what side effects you might be having and if there needs to be any dose modifications for the drug. We talked about Velcade causing peripheral neuropathy. Kyprolis or carfilzomib has a lot of cardiotoxicity, for example. And right now, daratumumab or Darzalex seems to be the most promising drug in terms of efficacy and side effect profiles. Again, Darzalex, just because I didn't mention it before, Darzalex is an antibody therapy against CD38. CD38 is a protein on the surface of plasma cells. Darzalex works by attaching to this protein on the surface of plasma cells and essentially calling all other immune cells to kill it, and is very well tolerated, and it can be given both as an infusion and as an injection. Once you go into maintenance with Darzalex, the dosing schedule also changes to where a patient might be getting Darzalex maybe just once a month. And again, this is very attractive in somebody who might not want to be attached to their infusion center every week or every other week. A monthly injection is a very reasonable approach in this setting. And this is a slide essentially looking at cost, real-world analysis of cost of Revlimid maintenance and len maintenance versus no maintenance at 0 months, 12 to 24 months, and 24 to 36 months, looking at inpatient costs, which is a very light purple, outpatient costs, and pharmacy costs. And you can see that as time goes by, while the lenalidomide group has a higher cost overall, those costs are split more in towards pharmacy and not so much inpatient costs. So for example, patients who don't get maintenance, they might have higher outpatient or inpatient costs because of relapse than those that are on maintenance. Ultimately, the decision to choose a treatment should be made with your hematologist oncologist, looking at a holistic picture, looking at everything, looking at patient preferences, their physical activity, their work productivity, any comorbidities they might have, quality of life, disease or symptom control, treatment-related toxicities, treatment convenience, and financial toxicity. It is a decision that we make together, and we talk about all the pros and cons along the way. So to conclude, maintenance therapy is standard of care in newly diagnosed multiple myeloma patients. It improves outcomes, including prolonging overall survival, time to next treatment, and overall patient quality of life. Again, if you have a longer remission duration, that's a period of time where you're not needing active treatment for multiple myeloma. Right now, lenalidomide remains the preferred agent of choice, with multiple other options available under specific circumstances, like we discussed for the daratumumab and the carfilzomib. And with that, I'll end and see if there's any questions, and I'll turn it, I think, over to Marla.
Thank you, Dr. Bachier, for that excellent presentation. We'll now get to some questions. If you have a question, please enter it in the chat box on the left side of the screen, and we will answer as many questions as possible. So let's get started here. Are there any predictive biomarkers to determine who will benefit from melphalan and how deep and durable the response may be? Some patients get zero benefit.
Yes, so I alluded to this a little bit previously. There's no specific biomarker per se, but there are cytogenetic changes, and FISH stands for fluorescence and cytohybridization. These are genetic studies that we do in newly diagnosed patients. There are known changes, there are known cytogenetic changes that predict for what we call chemoresistance, so resistance to chemotherapy. Melphalan is an alkylator. It essentially acts by causing DNA damage in malignant cells. Patients who, for example, have a deletion 17p or TP53 mutations, they're resistant to chemotherapy, to conventional chemotherapy. That's why in specific patient populations, more targeted therapies or biological therapy or immunotherapy is preferred over conventional cytotoxic therapy. Nonetheless, there is still value in cytoreduction with melphalan. But yes, patients who have these high-risk cytogenetics tend to be more chemo-resistant. So while there's no specific biomarker, there are cytogenetic factors that we take into consideration.
Great. Thank you for making that clear. The next question is, are there times you feel it is safe to discontinue maintenance?
Yes. So while not everybody has access to these next generation sequencing tests, in academic institutions, the use of this test was predictors for stopping therapy. So patients who had a negative NGS or next generation sequencing therapy was stopped. I will say that if I have a patient who has been in a complete remission for 3 or 4 years, I feel it is safe to stop. I always make the caveat that, it'll still probably come back. But after 3 to 4 years, if a patient has maintained a complete remission, meaning they don't have any M spike, their bone marrow has less than 5% plasma cells, I do stop those patients at that time. So it's 3 to 4 years complete remission.
Thank you. Upon relapse after transplant, should you immediately undergo another transplant, or is there a medication that's okay to take first?
It really depends on when you relapse. And I know that's probably not an answer, but if somebody has relapsed, 2, 5, 7 years after transplant, meaning they had benefit to the transplant, then yes, we'll consider a second transplant in that case. Nowadays, however, CAR T-cell therapy, chimeric antigen receptor T-cell therapy, is available as second line in patients who relapse after front line. So we might take into account, how soon did they relapse? Did they relapse within a year? If you relapse within a year of transplant, a second transplant is unlikely to do any benefit, and at that point, we would move towards other cellular therapies like CAR T-cell. So again, it depends on what the timing between transplant and relapsing, and other factors like the patient's age, comorbid conditions. But the bottom line is we will do second transplants if the first transplant was effective, and for us, effectiveness is 2 or more years of remission.
Thank you. And this kind of leads right into the next question. Someone asked, what are the factors that are important to consider in regarding CAR T for multiple myeloma if the first line fails?
So again, right now, CAR T-cell is approved for second-line therapy. CARVYKTI specifically is the one that's approved. For CAR T-cell therapy, a person has to have an adequate performance status. For us, that is somebody who is able to manage their daily activities of daily living. So somebody who can shower independently, can eat independently. So that's performance status. Number 2 is organ function. Prior to getting the CAR T-cell, the person has to have 3 days of chemotherapy called lymphodepleting chemotherapy. This chemotherapy can affect the heart, the lungs, the kidneys. So we do test for organ function, and acceptable organ function is essentially, relatively normal kidney function, relatively normal heart. It doesn't have to be perfect. It just has to be acceptable. So organ function is the second. And then, of course, there's always things like, caregiver support. CAR T-cell is much like transplant in that it requires a lot of caregiver support, coming back and forth to infusion appointments, treatment appointments, and it is important to have somebody to be a caregiver. From a disease standpoint, we do CAR T-cell therapy even in patients who are actively relapsing, understanding that they'll need some kind of bridging therapy. Patients who have very rapidly progressive disease might not have time to wait for the CAR T manufacturing process. So that's another factor to take into consideration is disease kinetics, or how fast is the disease progressing. But that brings up a good point in that these decisions about CAR T and transplant should be made by a transplant doctor and by a CAR T doctor. So if a patient ever has any questions about whether or not they're a candidate for CAR T, they really should ask their local oncologist to refer them to a cell therapy physician, because it is a cell therapy doctor that needs to be making these decisions, not a local oncologist.
Thank you. And then another CAR T question. What maintenance meds are used in post-CAR T therapy?
Nothing. So there's nothing approved. So none of the trials had maintenance strategies post-CAR T. So when we give CAR T therapy, it's supposed to be, one and done. CAR T cells are cells that are actively living in the patient's body, so it is called a life therapy. Once these cells are manufactured and reinfused, they tend to persist, right? They persist for some time, and the idea is that the response is ongoing. So even if you don't have a complete response at 30 days, you can still have a response at 100 days or 6 months, because the cells are still working in the body. So as of May 4th, 2025, there's no maintenance after CAR T. That might change. And the reason that might change is that CAR T isn't perfect, and we know that these cells don't last forever. They do poop out, so to speak. It'll be interesting to see what the next 5-10 years come up with in terms of strategies to essentially boost these CAR Ts to keep them working in the body. But as of now, there's no maintenance after CAR T.
Thank you. Next question is, my oncologist says of all the emerging myeloma treatments that might help me, the most helpful might be tri-specifics. How much more effective do you think those will be? How hopeful are you that they will be better than bispecifics? And what do you think is the possible timeline for them being available? And I can break that up for you if you need.
So when we talk about bispecific antibodies, the idea here is, and this is, immunology 101. So there are many different cells in the body, and one of those cells is called a T cell. T cells are in charge of killing other cells, cells that are not supposed to be there, including myeloma cells. And so bispecific antibodies are antibodies that have two signals, let's call them. One signal is for the T cell, and another signal is for the myeloma cell, so that when this antibody is infused in the body or injected in the body, it is going to bring together the T cell with the myeloma cell so that the T cell can kill the myeloma cells. And right now there's bispecific antibodies against two tumor markers. One of them is BCMA, or B cell maturation antigen, and the other one is something called GPRC5D. And again, the idea being that you bring together the T cell with the myeloma cell. The thought process behind bispecific or trispecifics is that you have more tumor antigen to target. Right now, combinations of bispecifics are being used. So bispecifics against BCMA in combination with bispecifics against GPRC5D. Again, the idea being that if you have more signals to find more myeloma cells, you could potentially bring more T cells there. One of the things that happens in multiple myeloma, and again going back to clonal evolution, is that these myeloma cells become smart. So if they see that they're being attacked via, for example, BCMA, they will shut down BCMA, so to speak, and become resistant, for example, to a drug against BCMA. Alternatively, if you're targeting GPRC5D, the myeloma cells might say, oh, wait, they're killing me because I have GPRC5D, let me shut that down. With trispecifics, the thought is that you're exerting pressure on different sites so that it, and I'm trying to simplify this as much as possible, so that the myeloma cells get kind of confused and don't have a real chance at downregulating or upregulating a specific receptor. This is still a few years down the line. I would say probably 2 years or so. One thing that I'm actually more excited about than trispecifics is CAR T cells targeting dual antigens. So, for example, CAR T cells against BCMA and CD19. Again, the whole idea is that you're trying to attack the myeloma cells on two fronts and not allowing it to become resistant to one or the other, if that makes sense.
Thank you for that detailed answer. Is PET-CT scan for multiple myeloma relying on the same fact that multiple myeloma has much higher uptake of glucose than normal plasma cells? Do we know how much higher the uptake in glucose is in general?
So yes, so the reason PET-CTs work is because cancer cells divide more rapidly, therefore take up more glucose than regular cells. So that's exactly how PET-CT works. The myeloma cells will pick up the glucose preferentially, and that's why it lights up. In terms of how much more, it depends on how active and how proliferative they are. As an example, the baseline mean uptake of the liver is a number of around 2. Normally, myeloma cells, like run-of-the-mill myeloma cells, will have an uptake between 7 and 12. If the cells are very highly proliferative, it can be more than 12. But these are numbers that should never be interpreted by a patient and should be interpreted by an oncologist. But yes, the principle is that myeloma cells divide more quickly, therefore they take more glucose, therefore they light up on the PET-CT. And they light up more than the baseline of the liver, which is usually between 2 and 3.
If 10 milligrams of Revlimid caused definite IBS after 1 year, would Revlimid 5 milligrams daily be an option?
Absolutely. So earlier I talked about dose modifications. This is exactly that. If somebody is having, so the studies with Revlimid, and I didn't go into specific dosing schedules, but the initial studies with Revlimid were using a dose of 10 milligrams. We know that not everybody needs 10 milligrams, and if they can only tolerate 5 or even 2.5, that's better than 0. So yes, if you don't tolerate 10, you should go down to 5. If you don't tolerate 5, you can try 5 every other day. You can try 2.5. All of these dose modifications are made in conjunction with your oncologist. Never try to change the dosing on your own, but rather talk to your oncologist about the symptoms that you're having and tell them, please let's consider a lower dose. It is absolutely appropriate to do so.
Next question is, I would like to know more about extramedullary disease. How and why do the myeloma cells leave the marrow and travel elsewhere? The big question is, what does the future hold for me?
So when we talk about extramedullary disease, it's essentially plasma cells where they're not supposed to be. Plasma cells should be in the blood or in the bone marrow. Cells can have honing mechanisms to the skin, for example, the liver, soft tissues. They just migrate out because of homing signals that are not entirely understood. One treatment option for extramedullary disease is localized radiation if it's localized to one specific area. Extramedullary disease tends to be a little bit more resistant to conventional treatment. So when we talk about responses, we don't really talk about extramedullary responses necessarily, but they do respond. They just respond less than your disease inside your bones or inside the blood, and they just migrate because of homing mechanisms. It's not clearly understood which specific factors, just that there are factors that make it migrate into places they're not supposed to.
Thank you. Someone asks, you did not mention the particular side effects associated with Rev or Dara. Can you give us some of those?
Sure. So Revlimid, the main one is nausea, vomiting, diarrhea, so GI toxicities, rashes, and then low blood counts, for example. So Revlimid can cause neutropenia, meaning your neutrophils count can go low. And then over time, there is a risk of secondary cancers, more specifically skin cancers. Again, with dose modifications, these side effects go down. Darzalex, a little bit of GI toxicity, not a lot. A little bit of abnormal blood counts, not a lot. Mostly infusion reactions, so reactions associated with getting the injection itself, which can be as simple as a little bit of redness at the skin injection site or full-blown hives. So definitely very well tolerated in terms of the Darzalex.
Thank you. How impactful is deletion of chromosome 13?
So deletion 13 is a standard risk cytogenetic. It's not considered high risk. So it is not high risk. So it's not in my opinion. We don't use it as a risk stratifier because it's not considered high risk. It's just standard risk.
Thank you. Generic versus brand name. Any experience showing comparative efficacy?
They are both equally efficacious. The only difference is in side effect profile. Some patients tend to report more side effects with the generics, but efficacy is the same. Side effect profile might be different, but efficacy is the same. And again, the difference in side effects is very patient specific, not clearly understood why.
My son, who is 26, has multiple myeloma and amyloidosis. Would the myeloma have possibly caused the amyloidosis?
Yes. So you can have, not all amyloid comes from multiple myeloma, but if you have multiple myeloma and amyloid, then yes, your amyloid came from your multiple myeloma. Amyloid is essentially a consequence that happens when the abnormal proteins, the abnormal M spikes, are deposited in tissues. This doesn't always happen. So you can have multiple myeloma without amyloid, and you can have multiple myeloma with amyloid.
All right, someone wanted clarification on an earlier slide. They didn't think that DRVD was considered chemo, but your slide earlier called the maintenance drugs chemo.
I call everything chemo for basically just ease of the talk, in the sense that they're drugs that are given by an oncologist. Technically speaking, they're right. Revlimid is an immunomodulatory drug, and daratumumab is an antibody, which is also an immunotherapy. More specifically, when we think about conventional chemotherapy, these are cytotoxic drugs, things like melphalan, Cytoxan, Velcade, which is also in the proteasome inhibitors. But they are correct. They're not technically chemotherapy. I just, for convenience, call everything chemotherapy, but they are, I guess, biologic therapy.
Thank you for that clarification. This is going to have to be our last question. Is there anything that an individual can do to lessen bone pain?
I mean, it really depends on why they're having bone pain. If they're having bone pain because they have active disease, then hopefully treatment of the myeloma will help relieve that bone pain. If their disease is in remission and it's because of nerve damage, either from the disease or from the consequences of chemotherapy, then we use a lot of different drugs, including things like gabapentin or Lyrica, which really target neuropathic pain, or bone pain more specifically. Non-opiates and opiates are used. If the pain is because of a large tumor mass, we can consider palliative radiation. So there's many different things that can be used for pain. It really depends on why is the pain happening. And I would always encourage patients to be proactive and even ask for pain doctor appointments. There tends to be a lot of stigma around pain and opiates and whatnot. But myeloma can cause pain, and it is very important that we not forget about that. And sometimes having a dedicated pain team, either anesthesia pain or palliative care pain, sort of helps get a sense of why the pain is happening and how best to treat it, because there's no just one treatment. It will most likely be a combination of treatments, including things targeting neuropathic pain.
Well, thank you for that. And thank you for this wonderful presentation, Dr. Bachier. On behalf of BMT InfoNet, we'd like to thank you and thank the audience for their excellent questions. Please contact BMT InfoNet if we can help you in any other way.